So here we go. Hello everyone, and thank you for joining for the 6th webinar of the WFNS Radiosurgery webinar series. And I request my co-chair, Professor Selçuk Peker, to introduce our invited speakers today, Professor Andrei Golanov from Russia. Professor Peker.
Thank you so much, dear Manju. Today, our guest will be Dr. Andrei Golanov from Russia, and he is a very good friend of us for many years. And I will give a small CV of him after Manju opens the PowerPoint.
Sure, I'm opening it. Is my screen visible now?
Okay, yes. So
yes.
Professor Andrei Golanov graduated from Moscow's Second Medical Institute. He was among the first Russian practitioners to introduce the technology of stereotactic radiosurgery, including gamma knife. He is an experienced neurosurgeon and for years has been involved in the treatment of many tumors and using of stereotactic method in the treatment of oncological and functional diseases of the nervous system. Professor Golanov received a second specialization as a radiation oncologist in 2004 and subsequently became the chief of the Department of Stereotactic Radiotherapy and Radiosurgery of the Burdenko Neurosurgery Research Institute in Moscow. And Dr. Golanov has worked in hospitals in Western Europe and USA. In 2011, the department of and personally Professor Golanov became the first Russian winners of awards for radiation oncology in Vita Veritas. He is very active member for many international scientific societies such as WSFN, ESSFN, ISRS, RSS, ESTRO, etc. And we are very happy today to have him as a presenter for craniopharyngioma. We all know that craniopharyngioma is an important problem for neurosurgery. And today we will hear his presentation, the latest situation for radiosurgical treatment of craniopharyngiomas. Andrei, stage is yours, please.
Okay, thank you so much. Thank you so much for nice invitations. Thank you very much for your presentation of myself. So, dear colleagues, dear Professor Tripathi, dear Professor Peker, the real interesting to be here and present our materials, our thinking about this. I would like to say some first words that before we discussed with Tripathi some questions and some points that we have lighting in our presentation, because you see and you know that it is like something before we start to write the chapter for the international book of secrets of radiosurgery, and now we discuss some points for maybe more clear for us that we have light and that we have be in our mind when we talk about the craniopharyngiomas. Generally, I would like to say that let me be direct. These questions reflect that the center of attention we face every day. It's a conflict between surgeon's ambition and the patient's long-term well-being. Because you see, the first slide. I would like to first start from some history points. Craniopharyngioma describes the first by Friedrich Albert von Zenker, who identified a group of cells resembling sclerosing epithelials located in the part tuberous and part distalis of pituitary gland. 1959, Jacob Ertheim describes the histological characteristics of craniopharyngioma in adults, mostly found on the anterior surface with an infectibulin group of the isolates, variable size, shape, and number. 1909, the first successful surgery attempt of craniopharyngioma reflection was performed by Hersted from Chicago. And in 1932, Sussman was the first to detect squamous epithelial cell nests in the pituitary gland of the children. 1932 is the same year. craniopharyngioma was named by the first introduced by Harvey Cushing. He utilized the transfemoral approach for most of these pituitary gland surgeries, but advocated the transcranial approach for the craniopharyngioma. And also the very famous words by himself, this craniopharyngioma is the most formidable intracranial tumor. And we have some real basis for these words now. And we know that is true. So the other interesting point that I would like to say in the beginning, that the real first gamma knife patient co-treated with gamma knife was a boy exactly with craniopharyngioma. He treated before with by atrium 19 colored brachy. As a solid tumor remnant part, we have turning part, and then he fixed here to plastic scalp in Stockholm, and then going to the first places of gamma knives. It was some 100 kilometers from Stockholm. It was the first apparatus, the first gamma knife, and result we have them. He was treated with 20 gray for the center of tumor, and unfortunately he died 4 months later because of shunt occlusion. But during autopsy, found a small crystal of surrounding tumor tissue surrounding central tumor necrosis. So, in any case, the first patient with who treated with gamma knife was the patient with craniopharyngioma. Okay, let's go to the site of craniopharyngioma in general. Craniopharyngioma are rare benign epithelial tumors of the embryogenic origin that grow from the elements of Radke pouch and are usually located in the chiasmatic cellular region and or in the region of the third ventricle. What occur is the two age groups, 5 and 14 years and 50-74 as well. The incidence rate is 1.3 per million per year, and about more 1.4 per million in children. Craniopharyngioma accounts 5 or 10% of brain tumors in children, and is the largest group of extracerebral tumor in children. And also is account about more than 50% of chiasmatic cellular tumor in children also. Craniopharyngioma is the complex epithelial neoplasm of cellular, supracellular, and third ventricle. And now all tumors of this type subdivide for the two main groups, adamantinomatosis type and papillary type. It's some difference between these groups because the first adamantinomatosis type is most of the craniopharyngioma, the cyst and solid components, and more often performed in children. And this tumor is also more invasive growth and occur more often than papillomatose. That more common in the adults, typical solid structure head and clear plane of dissection, and less likely to recur and less grow potentially. You can see here is a little difference between the progression-free survival in these two groups, and as well as the histological features of each group that you can see. There are many classification of craniopharyngiomas that we can find in the literature, but we useful in our institution more often use the classification by Grekov modified by Steno, and subdivide the tumor for endocellular and supracellular tumors. Supracellular including the giant cystic forms, and craniopharyngioma of the third ventricle. Maybe the interventricular and intra-extraventricular as well. And initial growth point and localization of craniopharyngioma, it depends from the place of where is the origin of the tumor, and maybe, as I said above, supracellular and the supracellular and third ventricle group. I present the Burdenko Neurosurgical Institute, and now we have about more than 350 beds, and about more than 10,000 cases of surgery in per year. Our former director, Professor Konovalov, he is now his honors president, and now the director is our institution is Professor Usachuk. And you can see that now we have a material about more than 4,000 craniopharyngioma surgeries in our clinic, and now more than 100 patients with craniopharyngioma per year. By the way, Professor Konovalov, who is our mentor, and he is one of the pioneers of modern microneurosurgery. He has huge experience of craniopharyngioma patients and treated himself more than 2,000 patients himself only. And also our leaders for craniopharyngioma is Professor Kalinin, who is chief of the department of skull base, as well as Professor Gorelchev, who is chief of the department of pediatric neurosurgery, and also a member of the VVFNS neurosurgery endoscopy committee. So, what is about the surgery? Now the surgery is very, very high. We have a high level of microneurosurgery, and here you can see combination between the transcranial and endoscopic removal of the tumor with very good result. Also, we can see that how we divide our cases according to the radicality of surgery. For total, we can no visible residue of MRI, subtotal, small, and first of flat capsule remnants, volume doesn't matter, and partial tumor remnant with a measurable volume. And according to our radicality of tumors, most of them are removed with high radicality, but not only about the 40 or 50% with total removal. Now situation is a little bit better, and now the situation is changed because during Science 2005, we have the modern neuroendoscopic technique as well as a radiosurgery department in our institution, and situation around our patients a little bit changed. And now we have again the very nice radiosurgical department, and you can see also how changed the proportion between the transcranial and transpharyngeal approaches. Because now more patients with craniopharyngioma treated with transpharyngeal approach, more about the 80%, and only 20% with transcranial. And again, we more and more can see how the transpharyngeal and endoscopic technique lets us remove whole tumor without any remnant part. And at the same time, we have very nice number of complications, and that no mortality as well for these tumors. Any point that other point that the progression-free survival is strongly directed and strongly depend on the radicality of the surgery. And you can see that if you remove the tumor totally, we have the very nice number of progression-free survival, about 80% and more. And from other points, that the subtotal or especially partial removal is more than 30% of progression in these patients. So the same for the cyst drainage, of course. Our patients, because most of them, of course, have the progression and have some relapse. So the same number we can see in adult patients, because before I described our pediatric group, and now we can see that the non-total removal of tumor lead us to the very high number of relapses in these tumors. And other point is very important, that the primary, another results of the primary recurrent surgeries, because only the first attempt on the first diagnosed tumors in patients were possible have a good results for the total removal of tumor, more than 40%. And in the opposite, the repeat surgery, the more or less significantly less number of the good results, and we have progression-free survival rate only about 20%. What about the cis drainage? You can see that now we have absolutely clear information that not enough only puncture the key size and then stays the MRI system, because after some time we can see that the tumor cyst will become calcified and rigid and very difficult to remove. And in the same time, large volume for radiotherapy and do this treatment very difficult. So we can say now that the MRI system is not an independent method for treating craniopharyngioma. And of course, after this, we have or remove tumor or perform radiation of these tumors. Here you can see the nice example of such position. Here is the girl with cellular craniopharyngioma, and who was implanted by MRI system and then operated after 1 month with nice result. But unfortunately, he had one not so big relapse after 1 year, and it was the second operation, surgery, and removed the recurrence. But I again was after the 2 years, the new relapse in field of the operation. And this was irradiated with radiosurgery with gamma knife. And now we can see that she is an adult, she is a nurse, and very good condition. But we have this case, and you can see this picture after 9 years after radiosurgery without any sign of relapse. So we can see now that the radiosurgery and stereotactic radiation is very effective for the patients with the craniopharyngioma. And we use different techniques and different approaches of radiation. Here you can see on the right center, we can see the very nice result of conventional radiation and with the big tumor and with radiated with Novalis in classical style with 1.8 gray fraction, 30 fractions, and then after 6 years after this, we can see no tumor at all. So our position today is a subtotal transcranial removal, and that we add with stereotactic radiotherapy. And the same, we can see that even we can see there's a fast progression after transcranial subtotal removal, we also performed and recommended the irradiation of this tumor. One of the main questions that we discuss and that we meet every day is the growth of total resection still justified in the era of the modern radiosurgery? And we can see, we can say that complete cure for craniopharyngioma can only be achieved through the radical surgical intervention. But any alternative approach consists the patient to lifelong therapy. But we have had a balance between radicality and functional preservation remains a cornerstone craniopharyngioma surgery. Because is a radical surgery, radical tumor resection should be pursued, but not at all cost. This is very clear. And now our mentor, Professor Konovalov, said about this every day and said that we have not removed this tumor radically, because we have to save pituitary stalk, hypothalamus, optic nerves, and other structures. And so today we can say that the gross total resection is not a nice position in the era of modern radiosurgery, because we know about how effective the radiotherapy is, and also know that the higher radicality do and lead to high mortality. And we have morbidity, excuse me, and with a very high level of endocrinological, visual, cognitive, and other problems. So we can see that the gross total resection alone is lead also to recurrence. At about 10%, we have some number of relapses. But subtotal resection with radiotherapy also decrease the number of recurrence, but it's also it have. And so, but the stereotactic radiotherapy, subtotal resection radiotherapy had a very nice number at about 90% or more of progression-free survival for this tumor. And this is according to our results, and we analyzed the 700 irradiated patients. We can see that the progression-free survival is about 90% now. And our position now is that we have performed the safe maximal resection with radiotherapy. But of course, if it's possible, remove the tumor totally without risk for patients, we have do it. But if not, we have irradiated these tumors also. And we can see here that the again, that the total removal is a very, very contrast and opposite with the non-total removal. Very different cases of very numbers of relapses. But if you add our radiotherapy and radiosurgery to the remaining parts of the tumor, we can see the same numbers that we have and that we receive from the total removal. It's about the 90%, as the same that like surgery, the very aggressive surgery. So we can say the progression-free survival after total removal and our combined treatment are equivalent. And again, what about the surgery? We can see here that we have, so unfortunately, even no, I said above, no mortality, but hormonal deficit before and after surgery in different location of craniopharyngioma let us gain the very high number of some problems. And it's the same for endosupracellular craniopharyngioma, stalk craniopharyngioma, and even ventricular craniopharyngioma. So, preparative hormone deficiency is most pronounced in children with endosupracellular craniopharyngioma. And after surgery, the hormone deficit increases approximately the same level regardless of the localization of craniopharyngioma. At the same time, when we perform the not gross total removal of the tumor and add it with our stereotactic radiotherapy approach, we can see that very rare some problems with changing in hormonal status of patients, and not only in some cases, and very rare we have some decrease of the hormonal status of our patients. So in main our cases, endocrine function remained unchanged. So now we have again the two possibilities for craniopharyngioma: total removal and non-radical removal plus radiotherapy. We have do it. So again, because quality of life is absolutely different in these two groups, we can totally remove the tumor and again be in very undergone our patients very big dangers. Quality of life for the craniopharyngioma patients is not correlated with the gender, individual hormone deficiency, panhypothyroidism, diabetes insipidus, deviation of height from the hormone norm, growth rates. And endocrine disorders are sufficiently compensate but replacement and do not affect the quality of life. But when points that we can use for determination of status of patients is PES scale. And we can see here that this main characteristic of the condition of patient is CDS BMI that characterize the degree of damage of the encephalic region. And this one is disorders negatively impact the quality of life. Maybe it's not the real hormonal changes, but it's a real impact on the quality of life. Because we can see here how it's what changed, and how is depend from the where the tumor infiltrating the structures, and how we could change the structures and how we could damage them during the surgery. And we can see severe metabolic disturbance, vegetative dysfunction, psychological disorders, emotional lability, impaired memory, thermoregulation, and sleep-walk rhythm regulations also as well. So damage on the encephalic lead to these unpleasant points. And the main of them is obesity, because again, this one obesity and quantitative criterion is the SBMI. The body mass index is a standard deviation and is very objective, characterized the condition of the patient. And we can see that during the endocellular and the stalk craniopharyngioma, not involving short ventricle, and because before and after surgery, it was did not critically significantly after surgery and differentiated between each others. In this group of patients, it is advisable to aim for the total tumor removal during the primary surgery. But when we can see about the stalk CPA involving the short ventricle, we can see that the absolutely different numbers, and total subtotal removal of stalk craniopharyngioma and the craniopharyngioma of the short ventricle often leads to the encephalic obesity. Partial removal of appendix cyst using the OMI system does not cause significant changes in both body weight in this group of patients. And again, we can see here that the quality of life is totally different between total removal patients group and group with non-radical surgery and surgery with radiotherapy and radio surgery for a residual part of the tumor. Very nice examples I can show you for according to these words. Here is a girl before surgery of the craniopharyngioma, and this one is her MRI pictures after surgery. No remnant part, no relapses. It looks very nice from the picture, but you can see that the absolutely different girl we can see here with real obesity and severe metabolic disorders and mental and emotional disturbance. And as an example, short ventricle craniopharyngioma combined treatment for 15 years ago. Before surgery, after partial removal, radiosurgery performed, and 5 years later, combined treatment, no tumor at all, and absolutely nice young woman, nice girl, with very high quality of life. So it's according to this algorithm for choosing treatment. You can see for craniocarcinoma, and we have preserved some small tumors due to the necessity not damage the hypothalamus and the encephalic region of this tumor, and we can use the ones as radiotherapy for this. And from other points that and the supraciliar craniopharyngioma without involvement of the floor short ventricle, we have that low risk of hypothalamus damage, and craniopharyngioma with involvement of the floor of the short ventricle, craniopharyngioma of the short ventricle, high risk of hypothalamus damage. And again, we can use the additional approaches of additional OMI style system implantation or synthetic radiation therapy for these patients. This is nice examples of radiotherapy for residual part of craniopharyngioma as before surgery and 10 years after surgery and radiotherapy, adjuvant radiotherapy with no remnants and no relapses in these patients. This example of when we do not perform surgery before due to the small tumor and what we show in diagnosis, and this was a patient for hyperfractionation approach normal visual acuity, no visual fields, and so small supracellular tumor. And we irradiated, and this one you can see with a histogram and some parameters of irradiation, and nice results after this. Here is a result of this patient, and again, no tumor. It was before irradiation, very close localization to the chiasm, and so we use hypertension approach. And again, the patient with normal visual acuity and normal visual fields. So here you can see how it changed the volume during after the treatment for a long time of follow-up. And this is for the treatment, the first, then 6 months more, 12 months more, and then you can see less and less volume of this tumor. Other point when we have, of course, it's not the 100% of the results and the effectiveness of stereotactic radiosurgery. Of course, question is why? Because sometimes it depends from the our accuracy during the contouring of the tumor. Here you can see the very nice line of radiation, but you can see a little remnants part that not included in the radiation, and for after 1 month, and then we can see one relapse here. So this is a point for discussion, and this is a point for more carefully and more accurately contouring of the tumor, and as well, or maybe we have, and sometimes now we think about the pre-surgery neoadjuvant radiation of craniopharyngioma. Maybe it's sometimes better because nothing change our mind, and we can see tumor as well itself. So what about the transient enlargement of cyst after radiation? It's really true, and sometimes you can see very high enlargement. For example, here, MRI was performed after transnasal evacuation. Radiotherapy was performed in 1 month after surgery. No kid cysts as well, with hypertension performed with CyberKnife, and then enlargement of the cyst after some months after the radiotherapy, but without any symptoms. And here, reduction of the cyst in the next 7 months after the this that we have, see how huge cyst we have, and again without any treatment we can see here that the cyst disappear. So we can say that we have continued follow up this patient, especially if we have no symptoms. Again, the other point and the other example, the same partial removal of tumor was performed. MRI, that we can see some remnant part of this tumor, and then we perform Novalis with conventional fractionation. Enlargement of cyst, also the same that we have before the first operation in 3 months after radiation, and that is called temporal epilepsy and spontaneous reduction of the cyst in 5 months after this picture. So, and letting the epilepsy regress without additional treatment. So our main point for this that we have continue follow these patients. After this picture, I would like to say that during 6 years more, no further growth and volume, all cysts are decreased significantly. So now we can say that the transient enlargement of cyst after radiotherapy is offer and occur about the 10% of our cases, and the duration of the occurrence about some months. But most of them decrease and go away even in 1 year after the operation. But again, we can say that we have keep in mind that increase of cyst volume in the early time after radiotherapy up to 1 year is highly likely to be transient. But only observation is required. The other point, what is the optimal management of recurrent cyst enlargement after the radiosurgery? So it's the same. We have nothing if it's asymptomatic, and only approach with and weight is a good one. But if you, of course, if you have some symptoms, we have repeat the surgical respiration or use some other drugs. And again, what do we have to do with the residual tumor after the radiosurgery, after the operation? Have we do some early radiosurgery? Now, there are some arguments for the early treatment and some for waiting. But our position now is more aggressively, and we can see that we have no time for wait, because upfront adjuvant radiation versus show us more good results for our patients. And we can see now that if you compare some our results with the results our colleagues from other clinics, we can see also that actually the progression-free survival is the same, and no real difference between these two groups. It was according to the group from MD Anderson Cancer Center, from São Paulo, and some others. And also we can see there's no difference between adjuvant radiotherapy and salvage radiotherapy. But we can see here the same results that we have also. No, but the main problem and the main point that if we can see complications during after the follow-up, we can see that adjuvant radiotherapy are much less problems with the patients if we performed it, if you compare in comparison with salvage radiotherapy. And when we irradiate it, when I have some problems with patients, and when tumor is enlarged or the tumor is gross. And the real result that we now today, we recommended receive immediately radiosurgery after surgery, because it's more good for the patient's quality of life. And also we can see that the endocellular remnants of craniosoma, even we don't see any remnant part of the tumor, we have irradiated endocellular as cellular, because these tumors, this remnant part are associated with the earlier tumor progression compared to remnants in the other location. So what about the radiotherapy, the radiosurgery technique for craniopharyngioma? Now here we can see the different approaches and different techniques that we use for our patients. We use different techniques. We use standard fractionation, hypertension, and radiosurgery. Usually we use the standard fractionation when there's a real big tumor and with which involved the chiasm and optic nerves are involved in the tumor, and so we use usually and no possibility to remove it. So we use the standard fractionation or conventional fractionation, and with dose 1.8 gray per dose and 30 fraction. And also we can see here the dose to the brainstem, the optic tracts, nerve tracts, and chiasm, and nice results. And for the standard fractionation as well, for head connection, the surgery as well. And no real risk for new endocrine disorders, and no risk of hypothalamic disorders as well. So what about the maximum safe chiasm dose in one fraction for gamma knife or the cyber knife? It doesn't matter. Now a little bit change our position, change our mind, and today we have used usually more higher number of it, and sometimes up to 12 rays per endpoint. And so again, there are no real dysfunction of and vision we can see in these patients. So what about the single fraction and hyperfractionation? As again, we can see that we use gamma, some plants with gamma that were treated with gamma knife for one fraction surgery, radiosurgery, and different examples of it. And usually it is not the big volume and a little bit far. I mean, the 1 or 2 or millimeters from the chiasm or optical nerves. And so this is a position I will also is agree with the other points and other mentions that we have from the other colleagues from Stanford, for example, for Quantec also, that sometimes is possible decrease the risk up to 12 grays for the nerve. And a little higher than before, when we said that the 8 or 10 is the maximum. Also, this is one example of treatment with gamma knife. After the transnasal system emptying, and we can see the solid tumor and radiated with those 16 grays. Now we prefer using the little bit higher doses at about the 18 grays, and have nice results for this. Again, with some problems for the vision. Here you can see that when we prefer use hyperfractionation for our patients. It's the same as the other colleagues from other clinics, the same results we can find, and use this number and this parameters for irradiation. Again, now ideal dose in our practice is when there's some not the big tumor and a little bit far from the chiasm, or enough 1 millimeter or 2 for especially for gamma knife, a little bit far from cyber knife, and if you have some more closer to chiasm, we use hyperfractionation, and today we use not the original dose like some dose about 25 grays, but use 7.5 in fraction. And for a large tumor or is involved in the chiasm or optic nerves, we use a standard fractionation with stereotactic orientation and 30 fraction with 1.8 grays per fraction. And the same contrasts that we can see here for the brainstem and for optic chiasm. So again, we use now, according to that we have techniques that we have, we use different techniques, and it depends our decision about from the tumor location, proximity of the optic chiasm, and of course we try have more tumor control and use more higher dose that used before. And this is some examples of is using hyperfractionation schemes with CyberKnife. It's again that we use enough so often for our patient, and some also some examples of plan of the symmetric plan for our patients. Here you can see again the tumors, how it's green line is 12 grays, and that 50% of those is yellow one prescribed for the tumor. As example, using the nice example of and the follow-up result using hyperfractionation with gamma knife after partial transnasal resection of craniopharyngioma. Tumor volume was about the 5 CAC, and again the scheme 27.5 in 5 fraction, and then a little bit increase to 1 cc, and then also complete tumor regression and volume less than 0.5 cc. What about conventional reduced fractionation? Again, we use it for huge tumor when there's no possibility to remove it. And usually this scheme 1.8 grave and 30 fraction. We use for this Novalis system as well, TrueBeam STX, and very nice results in some cases, even in some months after the operation, after radiation, excuse me. So another example, and one more. Also with nice and no tumor, we can find even 1.5 years after the operation. So what is one of the questions that we discussed before is what is the ideal target of the cystic cerebrospinal cyst wall, solid nodal, or both? Now we can say certainly the both. We irradiated cyst as well as with this wall. And you can see that we can include in the humor in the so the solid component, the cyst also, because cyst wall is secondary lining and they must be eradicated to prevent the recurrence and fluid accumulation. So again, that we sometimes if there was a big cyst we put the MI reservoir before and drainage the tumor and drainage the cyst and then irradiated it. Here was some examples how we, after input the MI system, irradiate the tumor in the standard fractionation and with maximum conformity and perform some function of MI system during the irradiation, as such controls the tumor. And after this, for example, in like it's here, we can see that there is no change after the 6 years after the treatment. So during the treatment, during the radiation, we puncture sometimes this tumor and this cyst, and after this we don't touch it, but as the cyst no more grows after the radiation. Here we can see our results if we compare some groups with that we treated patients with gamma knife, cyber knife, and Novalis system, for example. And generally there are no different results, no difference between these some groups. We have tumor control about 49%, and sometimes about 10 or more temporary cystic enlargement, and the recurrence about 6%, but it's sometimes depend again from the contouring of the tumor. Our results in general are the same that we have in the literature, and other colleagues agree with us in the effectivity of radiation in different types. And again, we use the more and more these techniques in the different patients with different groups. It depends from the location, and depends from the localization, but not from the techniques that we use, gamma knife, cyber knife, or Novalis system. So we can see that we can say that the these factors that who determine our choose of the treatment is the proximity of the chiasm through tumor volume or shape, tumor position, but not the real technique. Every of each is has nice results for them for long follow-up for our patients with craniopharyngioma. What about proton? This is a very discutable question because now we can see and more data in the literature that proton is more effective, but it's look not in reality. It's look not like this because proton therapy is of course much more have more costly, the more in comparison with photon radiation, and we can see that if you choose the literature and try see how it's what is the results, general results is also effective. Of course, it's also effective like the photon radiation, but in reality, they're not more effective and have no advantage if we compare with our techniques we use with gamma knife or cyber knife, because it's if you can see if we irradiate the huge tumors or irradiate the little children, maybe it will be better use protons, especially for example with craniospinal radiation, like for medulloblastoma. But if we say about the radiation of intracranial craniopharyngioma, we can say that they're not really compare it, because usually compare protons and the distribution of physical dose with old techniques like conformal radiation or IMRT, but not the real new techniques that we have, for example, VMAT. And if we try compare these techniques, there are no real advantage of the protons radiation we find for these patients, and especially point that we have no data that show us the effectiveness of protons more and more higher than effectiveness of radiation with again with cyber knife or gamma knife or true beam STX techniques. Okay, what about the C-ion therapy? It's again, there some technical advantage and high relative biological effectiveness at protons, even and potential for maybe for the greater tumor cell kills, more conformal dose distribution, and maybe more shorter treatment course. But again, there are no comparative data for craniopharyngioma, especially just for this time. Has sharper penumbra, but may case also the mate late effects. By the way, for the protons, we can also see, because we have not protons, but we see some patients from the other clinic that have real protons problems after proton radiation and due to the damage of the proton. And also, very important, the only few centers worldwide, is Japan, Germany, or China, have this such equipment. And of course, again, the cost extremely expensive in this tumor. So maybe later we can use it, but now it's, but not now. Again, what is the question between the difference between the papillary or adamantinomatosis craniopharyngioma? Is you can see that the adamantinomatosis craniopharyngioma is more often than papillary craniopharyngioma. Age is a little different, of course, because mostly papillary is adult patients. Genetic is absolutely different, and we have some mutations like B-catenin and for papillary with BRAF mutations determined as well. Structure is more cystic and calcified. Papillary is more solid, well circumscribed. Infiltrates the adamantinomatosis more infiltrate hypothalamus and often cystic calcified again. And recurrency after tumor gross resection are more often than papillary craniopharyngioma. And still this time, there are no response of target therapy. But for papillary craniopharyngioma, when we with BRAF mutation, there are very shrinkage in some cases we can find in the literature. I have said that our study is going forward, and there's a new approaches to the treatment of the adamantinomatosis craniopharyngioma. Maybe the more details of integrity B-catenin pathway will be open in the close time, and maybe it will be a field for the new target therapy for this tumor. But now we can say that the BRAF therapy for and MEK inhibitors for papillary tumors, craniopharyngiomas, is well known. And today we can see that these tumors shrink before surgery of radiation after the BRAF target therapy. And also we can use this technique for treating residual tumor or disease after surgery, potentially delaying of avoiding the need of radiation and patients who achieve it durable reversible. And treat recurrence that way as well as alternatives of rare radiation. And but what I can say before this, that today the situation has changed, and we have some therapeutic evolution strategies in papillary carcinoma, and maybe we find soon some advantages for using the etymologist or carcinoma also. But now, any case we have and use maximal safe resection for our tumors. We consider radiotherapy for remnant part of these tumors. If papillary BRAF positive, we use inhibitors, the neoadjuvant if resection of risky or salvage, if recurrence with after radiotherapy, and the antimitosis and cystic granulomas, we consider my reservoir bracket for cyst management. So, as conclusion for our general results, I can say the next points. Total resection of carcinoma is justified in cases with a low risk of hepatogenic damage, hyperthyroidism, and visual impairment. In other cases, safe partial resection followed by radiotherapy is preferred option. Alternatively, neoadjuvant stereotactic radiation therapy may be considered if MRI and CT findings are conclusive and visual and hormonal function are intact. In most cases, any residual fragment of carcinoma, no matter how small, will become a source of continued growth, so it's recommended to perform SRT-SRS immediately. An exception may be children under 5 years old. And in these cases, close monitoring and radiation therapy can be performed as a first sign of continued growth. The target of carcinoma should include all parts of the tumor, the solid portions of cyst wall, including any remaining part of wall fragments in the tumor bed after surgery and any calcification. Comparison of postoperative MRI and postoperative images is essential when planning radiotherapy. Those limits for chiasm and optic nerve depend on the fraction regime. So it's how many fractions we perform. 30 fraction conventional radiotherapy, 5, and this more 1 fraction. Hyperfractionation is the most commonly used fractionation regime for carcinomas. This is because a single fraction radiosurgery can be incomplete of dangerous if the tumor has wider contact with the chiasm or optic nerves and the patient has normal vision. We try to use radiosurgery only when the target volume is small and does not contact the chiasm. Standard fractionation is used only for very large tumor volume. Proton therapy has small advantage over photon therapy, but it's more difficult to access, expensive, and in most cases it prefers as a given to photon radiation. Papillary carcinoma almost always carries with the BRAF gene mutation. Treatment with BRAF and MEK inhibitors like vimorafenib, codifenib, dabrafenib, tramicitinib for several months before radiosurgery helps dramatically shrink the tumor. This allows for more gentle radiation doses, protecting the optic nerves and hypothalamus. However, target therapy is not exotic because repeated tumors growth is possible after drug withdrawal. The median progression-free survival with drug therapy without further local therapy is approximately 12 months. Maintaining this effect requires a long course of treatment up to lifelong use, which may be accompanied with the side effects, fever, skin reaction. Therefore, anti-BRAF therapy is a adjunctive treatment option, and after significant tumor shrinkage, surgical removal of radiosurgery remains the standard of the achieved standard sustained remission. In the case of dermatomatosis, anti-BRAF therapy has not significant clinical value. In the cyst enlarged before 1 year of radiosurgery, it will most likely regress on its own and only require observation. If cystic portion of the tumor enlarged after 1 year of radiation, is through continued growth and additional treatment, cyst drainage, removal, and repeat radiation must be considered. Each platform has its capabilities, advantages, and disadvantages. We have 3 types of them: gamma knife, cyber knife, and true beam, and it's convenient to be able to choose the right instrument for specific clinical situation. More than 80% of stereotactic radiation needs for patients with craniopharyngioma can be met with either gamma knife, icon, aspirate, or cyber knife alone. The current rate of any residual fragment of craniopharyngioma reached 90% after 10 years of follow-up. The late diagnosis of recurrence can be the result of due to poor patient compliance or radiologist's lack of previous images of comparison. For this reason, we believe that the radiation therapy for the fragment before continued growth is justified. Total dose for craniopharyngioma depends on the again from the fraction regime, and you can see here. And carbon ions have a very high relative biological effectiveness. Craniopharyngioma is histologically benign tumors that respond well to much less aggressive radiation. So slightest error of microshift in the beam can lead to severe and irreversible damage to adjacent normal structures. The use of carbon ion therapy is the most often excessive and unjustified. However, it's possible within the framework of the criminal protocols and after all other options have been exhausted. Repeatedly recurring craniophryngiomas that have already undergone several courses of standard proton-photon and proton radiation have become resistant to radiation. Malignant transformation, sometimes it's happened, very rare, but it's happened. Of craniopharyngioma, extremely rare cases of generation into craniopharyngioma sarcoma. And papillary endometriomas craniopharyngioma have several differences between typical age, diagnosis, tendency to form cysts, invasiveness of surrounding brain structures, and aggressiveness for growth, and which significantly influence the surgical tactics. However, the criteria for deciding stereotactic radiotherapy are virtually identical. So, in the final words, I would like many thanks to my colleagues who performed and helped me this and prepare this presentation. And of course, everybody of them, I mean, it doesn't matter, is surgeons, is radiation oncologists, is ophthalmologist, endocrinologist, and of course, medical physicists, help us treat this very hard and not the easy group treatment and have nice results that I can show you before. Thank you so much for your attention.
Thank you so much, Professor Golanov. You have made a real feast of craniopharyngioma radiosurgery, actually. This is such a complicated topic, and you practically touched upon all the controversies which happen in this one. One very interesting part to see was that cystic enlargement. That was a dramatic cystic enlargement at 3.5 months, and then dramatic resolution without any intervention. I haven't seen that sort of an enlargement at any point of time. Professor Selçuk, have you ever seen that or noticed that sort of a behavior?
Not that much, of course, but if I see this much of cyst development, of course, I would send the patient for surgery. But from Andrei's presentation, we learned that in some craniophryngiomas, we may see some temporary cyst enlargement. So as a small question to you, Andrei, do you have any idea about the mechanism for this temporary cyst development?
No, sorry. some reactions, some I don't know what when we say about the pseudo progression, have only say about some I don't know some reaction of cells of some proliferative some cyst. I have no idea generally. But it's a very interesting question, of course. It's a biological question. By the way, I think we have think about this, maybe discuss with our biologists or morphologists more carefully.
Manju, can I continue with a few short questions?
Please.
One of them, Andrei, we all know that craniophryngiomas invade the neighbor tissue, neighbor brain tissue. It's like a small fingers in the tissue. So because of that, in some patients, you do see, even you remove the tumor totally, you may see a recurrence. So if we think that craniopharyngiomas may have this kind of finger-like infiltrations of the neighbor tissues, should we use margins when we are irradiating these tumors? What is your opinion about it?
You see, I discussed this question with my colleagues, for example, Professor Gorelchev, who I can see him now, and we discuss about this. And usually, we don't radiate the place of craniopharyngioma, but it depends from the localization, because if it's possible, if it infiltrates the brain, it's more or less we can see it. But if it's we have some remnant part of capsule that will be deep inside in the cellar, for example, it's not impossible we visualize it, and so we have radiated the place of the tumor if we have in the cellar. But if concerning the brain parenchyma, I think that we see more and less and don't use PTV for this tumor at all, especially when we use radiosurgery or hypofractionation.
Sergey wants to say something. Please, Sergey.
Yes, thank you so much for the participation in this meeting. So I am a pediatric neurosurgeon and perform a lot of craniopharyngioma surgery. So I can comment that, of course, the radicality and the necessity for irradiation depends on the localization. So if we have an endosuprasellar craniopharyngioma, so it has no relation to the hypothalamic region. If we have a suprasellar pituitary stalk craniopharyngioma, it may displace, it may be in contact with the hypothalamic region, but in the majority of cases, it does not infiltrate it. So during surgery, you may carefully dissect the capsule of craniopharyngioma from the hypothalamic structures. But if we have a intra-extraventricular craniopharyngioma, which penetrates the third ventricle, so in this case, we have no definite border with the hypothalamic structures. Even we cannot identify them. So in this case, we perform the subtotal removal. So, and we intentionally leave some small parts of the capsula in this region. So this is the target for irradiation. So in this place, you are right that the craniopharyngioma may partly infiltrate with the small fingers into the surrounding tissue, but it happens predominantly in the hypothalamic region. And as I have told, this is the target, this is the place for irradiation.
Thank you so much. So can I ask another question, Andrei? You said that you try to keep the optic nerve less than 12 gray. So your maximum dose to the optic nerves and the chiasm is 12 gray. Is it correct?
Exactly.
So
sometimes yes.
Is it same?
Yes. Yeah.
Is it same for the pituitary adenomas, meningiomas in that region, etc.? 12 gray is your limit?
Exactly. It is possible, because of course we try avoid it, but it's if we have the very close position of our tumor, we sometimes use it. But if you have some more than 1 point, let me say, we prefer use hypofractionation. So
yes,
this is the point. But sometimes even 1 point is sometimes is possible, and up to this time we have not the real problems of these patients.
Of course, there are a lot of discussions in the literature about the maximum doses to the optic nerves and the chiasm. For example, in the article from Mayo Clinic, they said that 12 gray is safe radiation to the optic nerve, but many places in the world 10 gray is accepted as the safe radiation, but it's of course there are some different experiences in all
But
over
you
the
see,
world.
it's increased a little more year by year. So it's because
Yes.
sometimes before, some years before, we said only 8 grade, not more. But now it's
Yes,
then 10, and then sometimes about
you
12.
are right. And another question: for a small vestibular, for a small craniopharyngioma, do you see any difference between the side effects of gamma knife and other Linux systems for the same size
You see,
tumor?
we don't use actually as is very clear. We don't use Turing X for this. We use for radiosurgery. I mean, we use for example Turing X only for conventional radiosurgery or hyperfraction in some cases. But between the gamma knife and cyber knife, not the real difference up to this time. So it's generally the same results. But
Thank you
more,
so much.
the other point I have to say that if we have some very close chiasm, we prefer more often use hyperfraction for cyber knife. You see, because sometimes it's when we fix the frame and when it's for one fraction treatment, of course we don't choose our decision. But for CyberNav, if we have very close, we prefer use the hyperfraction again. So some less time we use for craniopharyngioma again. We use CyberNav for radiosurgery. I mean, radiosurgery one stage surgery.
Thank you. Thank you
One
so
fraction
much.
surgery. Yeah.
Okay. Thank you. Please, Manjul.
Dr. Andre, do you use any dose constraint for pituitary stalk?
We try use it if you can see it. We try use it, of course, but it's in general. If it's possible, see him. Of course, we limited our dose for it as possible, about 10 gray again. So it's about this.
And do you use, as most of these patients are the post-operative setting, so what specific radiological imaging you use for your target delineation? Well, sometimes they put the fat, so fat saturation images, T2, T1, what all do you use some specific images for that?
Yes, you see, you're right. We use some different technique and try compare the different possibilities of MRI, T1, T2, and sometimes fat set also. But usually the typical and prefer use a specific investigation, not during the treatment, especially with in patients with gamma knife surgery with frame, but study the features of the lung localization and how it's located the tumor before with some special, maybe some different MRI techniques.
We have a question from one of our attendees. They have asked, what is the algorithm for small tumors? Is it an adjuvant or neoadjuvant radiation therapy?
Usually we use, again, if you can some small tumors, we performed, and if there are no indicators of surgery, we perform the radiation. And after the remnant part of the tumor, we don't wait how it will be grows. Usually we decided perform the radiation before it grows. So with usually adjuvant radiation, but now again that we sometimes and think about this, that may be better before neoadjuvant also radiation. But because it's the fact that we will see more clear the borders of the tumor and capsule also.
They have another question. Probably they have found that optic chiasm Dmax for the 5 fraction different in the two slides. 27.5 gray or maybe 25 gray seems most common is 25. I believe means worldwide 5 gray in 5 fraction is the most practiced ones. So do you find any added advantage of adding 2.5 gray in that total regime?
Well, okay, you see, maybe some mistake, but usually we use a scheme of retention of tumor, like 5.5 for the radiation of tumor, but let's try keep 5.5. So only 5. I mean 25 grays per chiasm. So
Okay.
it's 5.5 for tumor and 5 per fraction for per chiasm.
My another query is for an interesting pathology in the same location, which is the Rathke's cleft cyst, though it is not craniopharyngioma. But have you some experience with the radiosurgery of Rathke's cleft cyst?
I'm not sure. I'm not sure. I'm not remember yet. I think I have not experienced something like this.
Neither me. So probably we had an article earlier on this, and they showed
Okay,
some
I can
evidence.
study our material and maybe contact with you.
Yeah. Do you make any difference in the dosing for solid versus the cystic component, if it is predominantly solid or predominantly cystic? As you gave a range of 16 gray to 18 gray.
Again, so it's not. We use the same radiation, but again, that's the main point that we radiated the whole tumor and without any, but 16 at least. 16 at least, but if it's possible, use and repose and using the for radiation using 18, we use 18, but usually 18 is more prefer use the 18 grays.
Can I ask you something about the cystic craniopharyngiomas? In some cysts, the cyst wall don't enhance with the contrast and contrast material. But in some cysts, we do see contrast enhancement. Do you include the non-enhancing cyst walls into the treatment plan?
Yes,
You do
right.
it.
You do it.
Okay, thank you.
Yeah, I think the main controversy is still lying with the definition of the tumor, as with your first question of the finger-like invagination into the hypothalamus, in the cellular component, in the supracellular area maximally. And if we are not sure where is our target, then probably we are missing some tumor. And that is the reason once we go for more for the fractionation side. One of the takeaway message for me today is that if you have a tumor which is responding to the targeted therapy, let the targeted therapy work so that the tumor shrinks. Probably the capsule also falls back. And then we are dealing with a relatively smaller tumor, which we can irradiate with the higher dose. Then probably we are more confident in our approach.
Exactly. You're absolutely right. Is my point.
Another important one is that with your, though the literature suggests that proton is probably better than gamma knife, but in your personal opinion and in your experience, you have found that the results are practically comparable, or probably they are better with gamma knife in comparison to the proton. Did I take the message right?
Yes, you're right, because you see, so first of all, I never see before the radiosurgery with protons as a result. From other point, I saw sometimes I saw some complications after protons more often than after gamma knife or cyber knife radiation. It's real. It's real because sometimes we really can see some bad results and real complication after protons, but not after the other techniques. So again, I think that it's funny for me. It's very strange when we can find in some literature or some people who responsible for protons that they compare the old techniques of photons with modern protons, and that's the show how was you see how it's better the protons. You see how was the distribution of those, how was better, how less normal tissue radiated, but it's not true in reality. If I'll show you some plans, for example, with turbinistic and new techniques. And of course, not it's possible not compare with distribution of protons with gamma knife or cyber knife, with a very, very huge gradient dose. So it's absolutely the different one. So, but again, so maybe maybe future. And the same is the literature. By the way, if you can see the real serious papers, that we can find that only one sense that the photons is effective, but that nobody says it is more safe for patients. More effective, yes, maybe the same effective, very effective, of course, not patients, but no more effective. So only you know, it's now the literature. Only for chordoms, maybe it's some have some sense. Only for these tumors we have some real sense, evidence based, but not for the craniopharyngioma.
And should I take it for the pediatric age group as well? Because that's that particular age group which has an adamantinomatous, which has no proven targeted therapy so far. And for them, they say that probably the proton is a better strategy. So should I take the same for the pediatric age group, or across the age groups? I'll take your statement as an equal response, safe response.
I think so. I think so.
That's very encouraging, actually, because the literature was actually the way it has been portrayed earlier, that used to lean towards one particular sort of a radiation.
Yes, but I think that any case we have, it is clear that we need more evidence-based data for the real comparison between the results in two groups and results between these groups with different techniques.
Thank you so much. If anybody has any question, we can direct it to Dr. Andre. As we are approaching our time today, and I request Professor Selçuk to thank our speaker, and
thank you. Yes. Thank you to Andre, and thank you to all the friends who joined this webinar today. And it was really, like you said, that it was really a feast for us, radiation for all kind of radiation for craniopharyngiomas. Andre, thank you so much for being with us.
Thank you for your attention. Thank you for support. Thank you so much.
Thank you so much.
Andrew, if possible, I call you if possible, okay?
Sure.
And because I will try to discuss what we have. Okay, this is webinar, but now our main goal is book. So we have think how we do for our book from this webinar, okay?
Definitely. I'm looking forward for your call. And this webinar recording would be soon available on the WFNS YouTube channel. And you should remain hooked to the social media channels so that we can announce the next webinar in our series. Thank you so much and have a good day.
Bye-bye.
Thank you for attending.
Thank you so much. Thank you, Professor Peker.
Thank you, Dr. Andre. Thank you, Dr.
Thank you. Thank you. Bye.
Thank you. Thanks a lot.